Hello, welcome everybody to the Community Hospital Association Q Community Special Interest Group. Fabulous to see you all here. We've been pleased to say that we've had over 40 people registered, so we may get people joining us at the early start of the session, but everybody's welcome. If I could introduce our speakers, and thank you so much for giving up your time to do this, really appreciate it at the end of a busy day. So perhaps Steffi, you could introduce yourself.
Hello everybody, my name is Steffi Bailey and I work for Sussex Community Hospital Trust on the south coast of England, and come to present today with Heather, who will introduce herself in a second, with regards to our end PJ Paralysis work that we've been doing across our intermediate care units. Oh, and I should say my job role, actually, shouldn't I? Yeah. I'm a physio by background, and I'm currently working as clinical transformation lead across the intermediate care units in Sussex.
Are you? That's very good to know. Heather, yes, please.
Hello everybody, my name's Heather Jackson, and my role is Trust-wide Falls Lead for Sussex Community Trust, and obviously I work with Steffi, and I too am a physio by background.
You're very welcome, thank you.
Thank you.
And we'll have Kylie, please.
Hi everyone, I'm Kylie and I work for Cornwall Partnership Foundation Trust, so right down in the southwest on the peninsula. So we cover Cornwall and the Isles of Scilly, and I am a quality lead. So I'm here today just to talk about one of our quality improvement approaches that we've done around timely medication for our Parkinson's patients, and kind of how we've used quality improvement methodologies to improve that.
Wonderful, thank you. And I should say that both of the programs you're going to hear about have won Community Hospital Association Innovation Best Practice Awards, which is fantastic. So we're pleased about that. Can I introduce our committee member, Tom Brooks? Tom, did you want to say a couple of words?
Yes, I'm Tom Brooks. I'm long retired now from healthcare management, but I sit on a number of committees representing the patient's interest.
Lovely. And I'll also introduce Eleanor. Eleanor's the person you'll have been communicating with, so perhaps say a couple of words.
Hello, hi everybody, nice to meet you. Nice to put some faces to names. Yeah, just supporting Helen with the event this evening.
Wonderful. And I'm Helen Tucker, President of the Community Hospitals Association, and we are getting extra people joining us, which is fabulous. So without further ado, shall we move on to Steffi and we'll hear the presentation. And just to let you all know, Steffi and Kylie have both kindly agreed that you can have copies of the presentation afterwards. But yes, if you don't mind, that would be lovely.
Yeah, I'm just going to share my screen, and I just have to warn you, this is always going to be the worst timing. I think all my boys are going to get home from football training. The dogs are going to bark just as I'm about to start speaking. So I'm really sorry if you hear about that in the background. It's always the way.
This is life.
Yes, this is life when you're doing these things from home. They can't sometimes be avoided. Can you see that all okay?
Yes, thank you.
Okay, so this is our presentation, and we're going to talk, myself and Heather, we're going to talk between us about the work that we've been doing across, talk a little bit about our intermediate care units, where this sort of stream of work has come from, a little bit about deconditioning, and then the programme of work that we've been doing for about the last 18 months or so across our units. So let's just see how we change to the next. Lovely. Okay, so across Sussex Community Trust, we have 14 intermediate care units, all based, some of the community hospitals have more than one unit in one hospital, but we've got 14 across the patch. And we refer to them as intermediate care units, abbreviated to ICUs, which can be very confusing between ICUs in acute setting, which means a very, very different thing from what we provide in our units. So we've got 327 beds across Sussex, some in quite rural areas, but we're all providing a period of rehabilitation and recovery to older adults with often moderate and severe levels of frailty. And partly this work has come from some of the changes that we experienced across the whole healthcare system during the COVID-19 pandemic, and we'll touch on that a little bit more as we go through the presentation. The other part of where this work has come from is a much bigger programme of work that has been running across our bedded units for about the last 18 months to 2 years. It probably started the first 6 months of a large piece of data collection to understand where we were at. But it's called the Community Beds Optimisation Programme. And it was brought about from recognising that the complexity of patients, the needs of patients, has changed with the advancement of community services and rehabilitation at home, urgent community response teams. So the needs of patients that were actually arriving into our units, as probably a lot of us have found across the country, has changed in terms of we're dealing with a much greater level of complexity in patients than perhaps we were doing 10 years ago, just through the nature of more mobile patients, more functionally able patients returning home with that community rehabs follow-up support. So we wanted to sort of do a big review to look at what is our workforce, what training needs for our current patient cohort, what are the digital systems that are in place to support all the workforce, what's the flow into our beds and out the other end of our beds, what are those processes? Because we're such a large geographical area, different practices of work had developed in different areas. So it was all about trying to get a little bit of consistency and equity of service. And also the biggie, what intervention are we providing for our patients whilst they're with us on our unit? So as part of that work stream, we developed a set of agreed rehab and recovery and palliative care standards that were kind of setting the expectation for what we wanted to provide consistently across of our units, that sort of all staff were signed up to, and patients could know that this is what they would receive on their units. And also as part of this, the end PJ Paralysis, recognising the impact of being in hospital for long periods of time and that the impact of deconditioning. So this is kind of the rehabilitative approach that we don't have it perfect in all areas, but this is kind of what we're trying to do. And as part of my role as clinical transformation lead, I very much work as part of the bed optimization program to work with individual units on this kind of right intervention work stream. So looking at that everything is person-centered, goal setting, intervention planning, thinking about things from an MDT perspective when we're thinking about goals and not just from a therapy perspective, that we start discussions about discharge on admission and we understand what matters to that person as they arrive on our unit, achieve a shared understanding and communication across patients, families and our wider MDT, a focus on function and promoting independence, rehab 24/7, supporting self-management, enabling and empowering our patients to make choices about their own healthcare and well-being, and then supporting our clinical leadership and decision making within our teams on the units. And the end PJ Paralysis work fits around a lot of that in terms of the rehabilitative approach. It's kind of the really nice starting point for promoting independence. So our bed optimization program started as we were coming out of the pandemic, but we did recognise as we started the right intervention work that there had been a change in the intervention that we were offering, the culture, the rehab ethos on our units because of the restrictions that were in place throughout the pandemic that we have all experienced, that social distancing, families not being able to bring clothes in for patients because they've not been able to visit. So the default was hospital pajamas, hospital gowns, rather than encouraging their own clothes. We lost that kind of ethos of going to the dining rooms for lunch, doing group activities in the lunch. We lost gyms and dining rooms to beds and other various needs. And then we had a whole cohort of new staff start in that really long period of time where we were in the pandemic, who actually hadn't experienced how our community hospitals had been running prior to this period of time. So even when we'd come out of the restrictions, we were looking at actually how can we get back to doing where we were before and making it even better. So Public Health England in 2021 produced a report describing the potential risk of increased falls due to the deconditioning that has occurred because of the pandemic, because that's the other element of the pandemic, was the fact that patients were at home, or people were at home and not moving around as much. I think for all of us, we had a very different change in lifestyle, particularly impacting those that are most at risk of deconditioning. And as a result of that, there's a suggestion, and I think we can probably subjectively see that our patients that are in our hospital settings now are more deconditioned, probably as a result of the pandemic and living through that period of more inactivity than perhaps would have been if people were out doing everyday activities as usual. So the impact of deconditioning, I'm sure we all probably know, but Professor Brian Dolan, who has kind of been the leader on PJ Paralysis, Last 1000 Days, all of those really important campaigns to highlight the impact of deconditioning and the impact it can have on people's quality of life, length of stay in hospital, and even leading to earlier death than necessary. It's that impact on physical, psychological, and function in a person, commonly occurring from a period of bed rest. And as we probably already know, 1 week of bed rest can equate to a 20% loss in muscle power and a 10% loss of aerobic capacity. And because of the system pressures over the last few weeks, I went into our local acute hospitals last week, and it was really, really busy. Very, our community hospital is very, very busy, but in the acute hospital, it is a different ball game in some ways. And seeing the pressure that they're under and the patients that were remaining in bed within their hospitals, and it's not a judgment, because it's really, really busy for those staff in those areas. But it made me reflect that actually, if one of our patients has spent 3 or 4 weeks within an acute hospital setting, and then they arrive with us for their period of rehab, the impact of deconditioning that has going to have occurred to those people before they even arrive at our unit is huge. And has a massive impact on all of these aspects on this slide. And I've just popped a link at the bottom there, and I'm not going to play it now, but Heba, who's going to talk in a minute, she shared this really lovely video with me a few weeks ago. I think it was produced by Healthcare 360, Professor Brian Dolan and his work team, just to get the impact of deconditioning to resonate with people. And I'd really recommend watching it and sharing it with your teams if it lands with you in the same way that it did with me. So I'm going to hand over to Heba.
Thank you. So in 2022, we came together as part of that right intervention group, as Steffi mentioned, thinking about how could we get back to providing really good rehabilitation on our wards. And we felt bringing back the PJ Paralysis campaign to the wards was a really easy place to start, because it was well known already. There were lots of resources and videos and things that we could utilise. And we also had force champions on our wards who I was working with, who could help us in doing the audit and sharing the message. So it was a good opportunity to start improving practice. So before we began, we wanted to do an audit just to see where we were at. And as you can see, 55% of patients were dressed in their own clothes, and 83% of patients were out of bed for lunch. And then in July 2022, we launched this trust-wide campaign. Okay, to the next one, Steffi. Thank you. So how do we do that? Well, the first thing was obviously to engage with the staff and to provide some training. So really small bite-sized sessions that were really easy to implement, handovers, the switch over from shift patterns. So there's lots of opportunities to provide these trainings, and we recorded some so people could watch them in their own time. We then had to also discuss with the patients' families and relatives coming in. And so we really wanted to introduce through the welcome meeting, when a patient first arrived on the wards, how important it was that they had access to their clothes and their shoes and their toiletries to really participate in the rehab programme. We already had there's a picture there of an ICANN board, so the white wipeable boards that staff could use with patients to help with goal setting. The idea behind I Can, if you've not come across it before, is, you know, you focus on the things that people can do already for themselves and then build on that, and to, you know, set new goals of what to achieve next. All the wards were given mobility milestone posters. So these were displayed along the walls, so distances people had walked, and so they could build up, set goals for the next one. There were some charts that some wards had, you know, introducing a bit of competition between people in a bay, that kind of thing. And then throughout the time, we also obtained feedback from staff and patients. Next one, please. So just to really understand, and just to remind ourselves really of that get dressed component of the PJ Paralysis campaign, you know, the hospital gown. I think this study really highlights really well what wearing a hospital gown feels like for people in hospital. And they, you know, this study looked at 938 patients, and they really pulled out 3 key themes that came with wearing a hospital gown. So this symbolic embodiment of the sick role. So I'm in my pajamas, therefore I'm unwell. You know, if you're dressed in your own clothes, you start to feel better and you're more willing to do things. There's an emotional and physical vulnerability, particularly with a hospital gown, you know, with it potential to be exposed and undignified. And then there's also a part of it where people are relinquishing control to medical professionals. So there can be a passive disempowerment. So we know that if we get people up and dressed, they're more likely and more willing to participate in rehab. So that was the message we really wanted to get across. Next slide. Conversely, getting staff to come in their pajamas really helped them to understand how people feel. And this is really widely spoken about within the PJ Paralysis world, and lots of staff have come in to work in pajamas. But one of the stories that has always resonated and stood out to me was an experience of a doctor on a ward who reported they normally went to work in a suit, and going to work in their pajamas, they felt really, they'd lost their identity. Lots of people even though they'd worked on this ward for 30 years or whatever, people didn't recognise them. And that was all just what they were wearing and how they appeared different to normal. Next slide, please. So the next part, so you've got the getting dressed and then the being active. So, you know, the real focus for us was around the deconditioning that was happening. And so we wanted to get back to a place where we were using our dining rooms again. We were now able to use our gyms. And so we really highlighted and promoted and pushed the benefits of having our classes starting again. And we continued to do this. This was Falls Awareness Week in September. And this is Lewis, so our ward in Lewis, where all the patients are actually in single rooms, so there are no bays. So, you know, the importance of coming out and socially interacting with others for meals or for exercise is really beneficial. And so this is our Falls champion who did the audit for us, running an exercise class, which runs every day just before lunch. So people come to the space for their class and then they stay in the same space for their meal afterwards. So it's working really well. Thanks, Steffi. So how do we measure? Obviously through audit. So we did the audit at the start and then we audited every month. So we picked a week in the month and they recorded the number of patients that were up and dressed in their own clothes and the number of people that were out of bed by 12 o'clock every day. And they did that for a period of 3 days over the week and shared that. Thanks, Steffi. And the great thing was that over the 6-month period we were recording this, we did see a big improvement. So there was an increase by 10% of patients that were in their chair and a 29% increase in patients that were dressed in their own clothes. So really positive results. And we wanted to celebrate that. If you show the next slide. We created some certificates that we awarded wards. So again, healthy competition between wards by having certificates awarded to those that showed the most improvement each month in either aspect, the getting dressed or the people sitting out of bed. Next slide, Steffi. Ooh, you skipped 2, sorry. And then the patient feedback. So you can read the comments there, but in general, we got really good feedback. Patients were feeling better. Staff reported that people were more engaged in their rehab. They felt better. They wanted to do more, and so getting dressed is really beneficial to patients. And this reflects what other wards and other areas have found as well when they've done the PJ Paralysis work. I think I'm back to Steffi now.
Yes, thank you, Heba. So, oh crikey, I just put my water bottle in mind. So it's all about, we did this initial work and found those improvements, and that was really positive, and we were celebrating, and the wards really liked receiving the certificates for when they'd made improvements, and when they were sort of the best performing wards for the month. But we needed to think about how we could sustain the improvements, continue to build on the improvements, and also measure them without trying to rely on our falls champions every month to do a sort of paper audit. How could we be more efficient in how we're gathering this data? So one of the big things for a lot of our units is the access to clothing, shoes and toiletries. And so some wards have set up a little area where staff bring in, if they've got clothes that might be appropriate, that they don't wear anymore, that might be appropriate for patients to wear if patients were willing to wear that and wanted to wear that whilst they're on the ward. So they have a little supply of different clothes that obviously would go home with that patient when they left. We had charitable funds that we utilise for some units where patients don't have proper fitting slippers, so we can access that sort of thing to support with that. And from a measurement point of view, we wanted to look at how we could use our digital systems and our electronic documentation program System 1 to be able to monitor this data on a monthly basis. So we, into our 4-hourly rounding templates, we built in an end PJ Paralysis template to that. So within this rounding template, the nursing staff and team are going round to review the patients. And so we thought that was a good opportunity to mark whether the patient within that template was dressed in their own clothes, what position were they in, were they lying on the bed, were they sat in the chair, and also some boxes to document whether they'd been engaged in any activities of that morning, whether they had been to the dining room for lunch, if they had had visitors. So we're trying to think more holistically about, rather than just has that person had a drink, have they been to the toilet, which it was quite a medical template before that. We've tried to add those bits in to think more holistically about physical, functional and social well-being for the patient whilst they're on the unit as well. And I can show you the dashboards that we're able to pull from those comfort roundings in just a minute. And it's the training and the promotion around end PJ Paralysis is ongoing. I don't think it will ever be something that we stop talking about in SCFT. At the end part of last year, we did another relaunch end PJ Paralysis week, whereby we said to wards, can you put on your own end PJ Paralysis event? And there'll be prizes for the wards that do something to kind of highlight the importance of Eat, Drink, Move, of Last 1,000 Days, of these really important campaigns. And we had some quite good uptake from wards who ran some various different things. I've got a photo in a minute of a team who all came in their exercise gear. Some people started doing activities in a different way to what they'd done before. But I really think engagement and just reminding people of the importance, and it has been really powerful. So this is the data that we are able to pull from our comfort rounding templates. So this gives us every month a percentage of patients. So it pulls one recording from each day, because the comfort roundings are done 4-hourly, but the system's quite clever. I don't know how they do it, but our business intelligence team, they work it all out for us. They pull one of the recordings each day. So the one that they would pull is when they're sat out in the chair, so that we get that data. We have had some teething issues with the consistency in how these templates are completed. With any change in process that we go through the bed optimization program, it takes time. But we can see that with green, it is really, really improving, and particularly on our dressed status. So our dark green is the percentage of patients that are dressed in their own clothes, the light green is the percentage that are in pajamas, and then the red is no data inputted. And you can see for quite a period of time we were really struggling to get this data inputted, but we ran a intermediate care unit bed optimization conference at the end part of last year. We actually did that in September, and Heber did a really brilliant stand at that in the workplace, where all of this data was visible for everybody to see, and that was really a catalyst when they could actually see the data showing them in the face at this conference. It seems to have been a real catalyst to get that data entry improved, because now from October last year we've really been able to have more of this data inputted, and we're back to being able to celebrate and send out certificates to those improving and most top performing wards again. Whereas when the data entry was a bit hazy, we couldn't really do that because we weren't able to see a really clear picture of what was going on. This is our lovely team in Bognor Community Hospital, who produced you can see all of the sort of advertising for PJ Paralysis that they produced behind them, and dressed up in their exercise gear for the day, which was brilliant that they sort of led that and took that on themselves. So yeah, really important. It's been a really great project to work on across our intermediate care units in Sussex, but I think me and Heather both know it's not a project that comes to an end, and it's just building on it, you know, getting patients down to the dining rooms for lunch, exercise groups, all of that is so important, and it takes education to all of our teams and support to continue to do those things consistently. And obviously when we're thinking about our cohort of patients, they are frailer, you know, there's some evidence by Dr Catherine Evans around community hospital discharges that often 25% of patients who are discharged from a community hospital may pass away within a year of discharge from our units. And so maximising their potential whilst they're with us is really, really important, and getting them back to where they want to be as quickly as possible is really, really important. And I always really like this slide, that often we're fearful of falls. We want to prevent falls from happening, but actually through doing that, we can immobilize people more, we can cause further deconditioning. So actually, let's reframe our thinking that through people moving more, through people being more independent and encouraged more, we're actually promoting more safer mobility, which in the long run will reduce risk of falls, rather than reducing length of stay, which we know, there's a lot of pressure across the system, and that we're actually trying to give our patients time back in their own homes with appropriate services. Days in hospital is days away from home. The patients telling us their stories rather than history taking. And hospital in the home, actually there's no ward like home, and that's Professor Brian Dolan as well, that he used that slide and that I've just pinched from there. So and another thing just to say before we go to questions, I'm really sorry if we've overrun. What we've started to look at now as well is the impact of long length of stay in terms of harm on our patients in our units, because we do have a lot of patients that wait a long time for packages of care, for placements, and we know that hospitals are great places when you need to be there, but when you don't need to be there any longer, actually they can be not very great places for our patients. So it is linked to the PJ Paralysis work, because we want to be able to monitor actually if patients through an extended length of stay where they don't need to be with us, where they're waiting for something, actually is there an impact to them in terms of their mental health, a decline in function, a decline in mobility, developing infections. So we've developed a tool again on our digital system whereby at certain trigger points within a patient's stay, we will complete that tool. It's a very quick and easy thing to complete, and it just gives a score at the end. And the higher the score, the increased likelihood that clinical harm has arisen through an extended length of stay. And it's quite new for us in SCFT, but we're just building a bit of a data picture around that. And I think that's really important in terms of the intervention that we provide for our patients when they're on our units, but also the impact of being in hospital for a long length of stay for our moderately to severely patients living with moderate to severe frailty and the impact that that can have, and the detriment that that can have to our patients at points. So I think that's all we had to say. I can stop sharing my screen if anybody has any questions.
That's good. So yeah, I'm going to talk about our Get It On Time Parkinson's medication that we've done. So similar to PJ Paralysis, this is a national campaign that we've kind of then localised within our trust. So I work for Cornwall Partnership Foundation Trust as a quality lead. So we'll very much talk about kind of the QI approach that we took around this. So our project team is pretty small. So Lynn Osborne, who is our Parkinson's nurse consultant, we've got Luke Huntley, who is one of our pharmacists, Jackie is one of our Parkinson's nurse specialists, and then myself looking at it from a quality perspective as well. So we were kind of the driving force behind getting the project up and running. So this is us down in Little Cornwall, in the southwest, so Cornwall and the Isles of Scilly, we can't forget. So we split ourselves into 3 integrated care areas across Cornwall. So we kind of have north and east, and then we have the central bit in the middle, and then we have the west area, which is my main area that I cover. But this project was kind of looking county-wide. So within that, we've got 10 community hospitals, including one on the Isles of Scilly, and that contains 15 wards, including our stroke rehab units. And then we also have community assessment and treatment units that are our kind of step down facility from the emergency department, or really help around that admission avoidance into the ED department. So they were set up through COVID and are really popular in terms of that kind of admission avoidance and that quick turnaround. So the aim of our project from a QI perspective was really to ensure Parkinson's patients within all our inpatient settings receive their medication within 30 minutes of the planned time. We started the project in March 2021 and it has continued since. And then that aspiration really is to ensure that the project work is embedded into the operational delivery on all our adult community services wards. So the reason that it's 30 minutes, so that is kind of the nice guidance, is that Parkinson's patients get their medication within 30 minutes of their allocated time. For patients that aren't getting their medication, it can have really detrimental effects to them. So patients that experience delirium, patients that are, their onset of symptoms becomes a lot worse if they're not getting that medication in time. So it was a really important one for us to focus on. So, yeah, like I said, it can lead to really serious health implications. And Parkinson's UK data is quite out of date. The data from 2021-22, where there were 1,075 admissions in Cornwall compared to a national average of 910 admissions. So we do know that in Cornwall we have got a slightly higher number of patients with Parkinson's disease, and a lot of that will come down to kind of the age profile and the demographics that we've got within Cornwall as well. And the average length of stay for Parkinson's patients had risen by 21.4% as well compared to the previous year. So we know that this was having a detrimental effect on length of stay for our patients down here as well. So that was kind of the driving force behind it. So what we looked at next is, as we're setting out this project, kind of what are the main measures and controls that we wanted to look at. So the first one was really around that improved staff knowledge. So raising that awareness with our staff, speaking to them to go, actually, what is the impact of patients not getting their medication on time, and just helping them understand the reasons why we were doing this. That awareness of time critical meds, so particularly Parkinson's medications, but just that awareness of actually the impact that that has. One of the measures is our reporting across all wards. So we do that on a weekly basis, where we send out reports across all our wards of their percentage. You'll see some of the graphs and figures on that in a minute. We did a patient survey, a staff survey, so that we can kind of look at what they're doing, and then that engagement with our inpatient wards as well. So because of the way we're quite geographically challenged sometimes in Cornwall, we really rely on having kind of link nurses on each of our sites and within each of our wards. So we will have things like tissue viability link nurses, end of life link nurses, and it was our meds management link nurses that kind of took on this role of taking on the project and kind of really embedding it into their areas. So we use that group of staff as a real kind of informal get-togethers with them on a monthly basis, but that kind of point of contact, should they need us to kind of come back to or raise concerns or questions, they're always kind of our driving force behind sending stuff out and making sure it's out there within our teams. So our journey on the project. So it all started in Newquay Hospital. So Luke Huntley, who is part of our project team, was our resident pharmacist at Newquay Hospital, and he had a patient on caseload with Parkinson's who he was really struggling to kind of manage and control his medication, and was really struggling with symptoms. And then he kind of had a deeper look into it and really realised the impact of Parkinson's patients not getting their medication on time. So just wanted to ensure with the staff team that that was happening and this patient was getting their medication on time. Once that happened, he noticed a vast improvement in this patient, and it was from that and seeing the real difference in this patient that he kind of took a lead on the project and was like, oh, actually, we've got something here, we need to do some work around this. So that's where it started, at little old Newquay. So from that, we then developed the project team. So Luke obviously got in contact with Lynn, who is our Parkinson's nurse consultant, and said, look, I really want to support with some work around this. I'm aware that there's a national campaign called Get It On Time, and what can we do really to support that? So from that, the project team was kind of born. So then we started emailing out. So started emailing out to Newquay first, just to say, look, these are your reports, these are your results that we're getting through, just so that they had that data at their level. And then as we did that, we did start to get kind of more feedback and communication from other wards going, oh, well, can you send us our data? What does ours look like? So then it kind of naturally started progressing in that way. We then started doing some educational masterclasses. So Lynn, who is our Parkinson's nurse consultant, did some online educational masterclasses around Parkinson's in particular, but time critical meds and what we can do around that. So we made sure those were really accessible for staff, and any conference or any big event that we could turn up to, we did, just to kind of raise the awareness. So then when I joined the project group, we started kind of pulling together a storyboard. So we could really help to articulate where we were with the project, both upwards to kind of exec senior leadership to get their buy-in, but also kind of out on the wards and with the team. So it's just a kind of one page project on a page type thing. That changes on a monthly basis depending what we've got, but just really outlines kind of what are we doing, what are the results, what have we learned so far, what are we implementing. So if someone was interested in it, they could just see at a glance what it was about and what we were doing. So then we looked at spreading it obviously across all of Cornwall and the Isles of Scilly. So slowly we picked up every community hospital and every ward and started rolling it out and just saying, look, this is what we kind of need to do. We used World Parkinson's Day last April as a real push for that as well, and a lot of promotion, and sent out kind of pill timer packs and things like that. And then we've been lucky enough to win some awards and kind of raise that awareness and celebrate some success around it. So that's kind of our journey, but I will go into some bits in a bit more detail. So what started off in typical QI fashion, which is what I love, as a kind of really small project within one community hospital ward, and it was one kind of test of change, has then kind of spread across the whole of the county, and we are now starting to work with the acute as well into how they can adopt it. So yeah, it's a lovely QI project to work on. I'm very lucky. So kind of some of our key successes. So it was, like I said, it was really small tests of change that we started implementing to kind of make it grow. So things like QR codes on posters, so people could access really quick videos. So these went up in a lot of the ward areas. Our meds management link nurses kind of printed these off and put them on their display boards and things like that. Just really quick kind of simple stuff for people to access. We started celebrating success. So in Cornwall Partnership Foundation Trust, we use something called the WOW Awards as our way of kind of celebrating achievements within our staff that both patients and staff can nominate for. So for every team that was improving and showing those improvements and doing really well, we would send out a WOW Award to them. So that's Tracy, one of our ward managers down at Catu, who they had shown huge improvements. So we celebrated with a WOW Award. we then used Well Parkinson's Day, like I said, to kind of send out pill timers and information packs. So in those kind of wash bags that we got all of this from Parkinson's UK as part of the National Get It On Time project. So there wasn't any kind of finance attached to it, apart from the pill timers that we bought. They were £5 each from Parkinson's UK. But so we got all of those bags together and put loads of information in those wash bags around supporting patients with Parkinson's, how they can signpost, who they need to come to. And then the aim of the pill timers is so that nurses can use them on the wards, but we also then share them with patients to show, look, this is what you might be able to use if they want to trial it, especially if we've got patients that are looking to be discharged home. Sometimes we will trial it to go, look, would this work for you out in the community once you're back home? And then we give them the details so that they can go and purchase one if they want to. We'd love to be able to give everyone one if they were discharged, but it's the NHS, we can't. But that really helps us to kind of look at some of our discharge planning as well and what we can do around that. So yeah, they've been really good in terms of helping to kind of improve that and setting the timers on those. So data that some of you will love and some of you will hate. So on a quarterly basis, so this has been running, like I said, since April 21. So what this graph shows, so these are all of our Parkinson's medication doses that have been given on a quarterly basis. So then what we did is split out how many we were delivering on time, and then the orange ones are those that are over 30 minutes. So when we started the project, 73% of all doses were being delivered on time. And in the latest quarter 3, we're now at 90% that are being delivered on time. So huge improvements, and it's made a massive difference to patients. So a 17% improvement. There are times where the amount of Parkinson's patients that we see is huge, and it's really increased in terms of the doses that we're given. We did notice a really big influx here, and a lot of that is with our community assessment and treatment units. Because the turnover of patients is quite quick, we do see a lot of Parkinson's patients through those units as well. So they have a lot of doses that they have to administer, but are still very good at keeping on top of it. We were worried knowing that our numbers were going to increase as to, are we going to still sustain this number? But as you can see, kind of from 22-23 quarter 3, so this time kind of last year, we've kind of maintained 86, 84, 85, 85, and then we got to 90. So we do have some weeks where some wards hit gold and we get really excited because they hit all 100% doses of achieving, and they'll always get a wow award in that case. We are still waiting for our golden week across the trust where every dose is delivered at 100%. We will get there at some point. It's a big aspiration, but we're looking forward to the week that it happens. So Luke, who is our pharmacist, will gather all the data, and he sends out a weekly email, and we just really in a really simple way, just celebrate success. So we started giving kind of a gold, silver, bronze award. So gold for people that were achieving 100%, and then silver was 95, and then bronze for anyone that's 90 and above. And even stuff like that, it like you said, it kind of encourages a bit of healthy competition, which isn't always a bad thing. But it just really got people kind of to look at their data and go, oh, actually, we only had 3 doses that were outside of the time. What happened there, or what was going on with that? So it just gets people looking at their data, and it's a bit more meaningful for them at ward level. So we're looking forward to the day that is 100% for sure. So in terms of patient and staff feedback, this is just a word cloud of some of the stuff that we've got, some of our patient and staff feedback. So patients and especially carers, we get really good feedback from, because often what can happen, unfortunately, in our trust at the moment, we don't have, in a lot of trusts, don't have a self-administration policy. So we do have self-administration policy within our mental health units, but not within our adult community services units. So what we find is that patients come in and they might be quite used to taking their medication and know when they need it, and then all of a sudden they're put in a hospital bed, and we kind of take that away from them. So go back to your deconditioning and removing that kind of enabling opportunity for them. So that can really have an impact on them. So I think them knowing that actually this is at the forefront of our mind in terms of them getting their medication on time and knowing that somebody is looking at that for them, it just has built a bit more confidence in them, and especially for their carers, patients, families and things like that as well. So they found the pill timers really useful, both staff and patients as well. Our pharmacy techs are amazing. They are really engaged on the ward. They really kind of integrate with our teams on the ward as well, and will help to push this for us as well. So if we are noticing a trend in any areas or any issues that are coming about, normally our pharmacy techs know what's going on and can let us know, so we can break down some of those barriers and see what it is that's happening. So it really is a whole MDT approach at kind of tackling this one. Then we move on to awards. So obviously we were very lucky to win a Community Hospital Association award for innovation and best practice. So when I joined the project team, which is about 2 years ago now, I don't think they quite realised how well they were doing, or that this was a great project. So as part of my role as quality improvement lead, I see it as kind of, let's celebrate and share success, and actually let's promote this and articulate the work that you are doing. So hence why I got it onto a storyboard, and let's share this, because it is really good what you're doing. So with doing that, obviously we got the Community Hospital Association Award, and then we were invited up to Birmingham for the Parkinson's Excellence Network Awards in November as well, and got highly commended for the Innovation and Best Practice Award there, which was for Lynn, who is our Parkinson's nurse consultant. I was super proud of her, because again, she just kind of thought, well, it's just my job, it's just what I do, but it's not. It's amazing work, and if it can be my role to help articulate that and celebrate that, then I feel like I've done a good job in being able to shout about it and do that. So yeah, really lucky that we're kind of starting to see awards. And as you'll know, once you start getting awards, it kind of helps to then get exec and senior buy-in attention a little bit as well. So we've had press releases and stuff like that gone out by the trust, and it just helps them with that buy-in of, then if we do want a bit more resource, or we want stuff to push, it does help, because they know that, oh, actually it's a really great project that we're getting good recognition for as well. So that's us at the awards. So next steps really, and what we're looking at doing. So it is pretty much embedded as business as usual now. We send the weekly reports out. People expect to have it. So our next steps really are looking at patient involvement in the project. So although we've had lots of patient feedback, we have a really good Parkinson's network of patients in Cornwall that feed back and feed into us a lot. But it'd be really nice to have someone kind of sit alongside us on the project team. Sustainability, so looking at the sustainability model and how can we make sure that this is sustainable if we didn't have us pushing it constantly. Not that we do have to push it constantly as much anymore, but as you know, it kind of always helps if you've got someone driving it a little bit. Lunch and learn events, so we have started to do a few of these, but we're looking at doing more where we can just do drop-in kind of lunch and learn events where people can learn about it, or we've got some of our kind of meds management link nurses that can talk about their experiences of it. We use a system called Rio. I know a lot of other trusts use System 1, but we have Rio, and we're looking at whether we can use Rio to kind of flag Parkinson's patients at admission point, so that it just flags to us as well, and we'll know, the Parkinson's nurses will know then, okay, there's a Parkinson's patient there, because at the moment we're very much reliant on referrals and stuff coming through. It's not an automated system. We have done some guidance for management of Parkinson's patients in an inpatient ward, so like all the kind of policy and process stuff that we need behind it, all that assurance stuff. And then the big one really for us over the next 12 to 18 months is implementing the medication self-administration policy, and how we would do that within Cornwall. So we are speaking with the National Get It On Time team to see what they might be able to help us with in terms of pulling some of that information together, because it's a really difficult one for us to tackle in terms of how patients can access their medication on the ward, the key safety lock boxes that we need. But actually, if a patient's got dementia, or they're quite delirious, or they're cognitively impaired compared to what they normally are, actually in terms of mental capacity assessments and things like that, it gets quite tricky. But we do know that at the moment that is a massive barrier for us, and it's something that would really support our Parkinson's patients to feel empowered when they come on the ward, that they can still take their medication that they've been used to taking for years, and they know what they're doing with, rather than at the moment them having to come in and hand that all over to go into the controlled drugs cupboard. So it's a work in progress, but we'll get there. And then the final one, so RCHT is Royal Cornwall Hospital Trust. So that is our acute provider in Cornwall. And we're doing some collaborative working with them of rolling this out. So we've really, they have sat on our project team for quite a while now, but more of a kind of watching and seeing what's going on. So we are now working with them to look at how we can really support them in rolling this out on their wards as well, because it's a really simple one to kind of pick up and move and take with them. So access to their data is slightly different than what we get, but it's definitely something that they can take forward. And that is it.